Right. Hi, I'm going to talk today about the trochlear nerve along with Ron. So I'll start by talking about the anatomical course and the function of the nerve, and then Ron will go on to explain examination of the nerve and palsy of the nerve. So the trochlear nerve is the fourth cranial nerve. It's the smallest cranial nerve by number of axons, but it has the longest intracranial course, and this means that it can be susceptible to damage from intracranial changes. For example, during trauma, or the brain can move around, or knee persons which can compress the nerve. It has a purely somatic function. So the trochlear nerve begins in the trochlear nucleus within the brain, which is just here. It will then exit the midbrain from the posterior aspect, and it's the only cranial nerve to exit posteriorly. All the other ones exit anteriorly, so you can see them here, and then the trochleus back there. So from here, it runs anteriorly and inferiorly within the subarachnoid space. So it goes around there. And it will then pierce the dura mater adjacent to the posterior clinoid process of the sphenoid bone. And that's this little point just here. And once it's pierced the dura mater, it will move along the lateral of the cavernous sinus, along with the oculomotor nerve, the abducens nerve, the ophthalmic and maxillary branches of the trigeminal nerve, and the internal carotid artery. So you've got your cavernous sinus here, and all the nerves running through there. And it will exit the cavernous sinus and then enter the superior orbital fissure. So the trochlear nerve only has one function, and that is that it innervates the superior oblique muscle. This is a muscle of ocular motion. So when you're looking straight ahead or outwards, i.e. when your eye is abducted, it will cause medial rotation of the eye. But when you're looking inwards, so your eye is adducted, it will depress the eye, and this is one of the muscles used in reading for this reason. So the tendon of the superior oblique is tethered by a fibrous structure known as the trochlea, and that's where the nerve gets its name from. So the trochlea is this little point here, and you can see that the superior oblique hooks round onto it, and that's what gives the muscle its unusual action. So you've just got a video that explains a bit more about the superior oblique dysfunction.
So this is the eye in the primary position, straight ahead position. The red ribbon is your superior oblique elbow. This is the eye in the primary position, straight ahead position. The red ribbon is the superior
Yeah.
The eye in the primary position, straight ahead position, the red ribbon.
If you stop it, then take it off.
So this is the eye in its primary position, straight ahead position. The red ribbon is your superior oblique tendon. And as you can see, when we rotate 36 degrees outward, then the straight ahead position towards the tendon is now 90 degrees, so that when there's a flexion of the tendon, there's a pure intorsional movement. Okay? Where the straight ahead position again, it's 54, and then when we go all the way in at 54 degrees, and there's a flexion of the tendon, you now have pure depression. Okay? And then going back to your straight ahead position right there.
So that was, what was that? So that just explained the motor aspect of it. Now you examine the trochlear nerve along with the abducens and the oculomotor nerve when you test for the eye function. So that's when you do the H test, so when you get the patient to follow the tip of your finger or the tip of a pen. And also you test it when you do the visual acuity test. This can be done using a Snellen chart, which is a chart with all the letters of the opticians, but more commonly done with reading a newspaper or a book because it's one of the muscles used in reading. We also ask the patient if they've been complaining of any blurring or double vision, and in medical speak that's diplopia. Now, trochlear nerve palsy is actually one of the hardest cranial nerve palsies to diagnose because it doesn't really present with all that much. Patients will come to you complaining of vertical and torsional diplopia. They won't actually say that, but they'll complain of double vision, especially when looking down and in. So that's when they're reading a book or walking downstairs. I'll come back to the different types of diplopia in just a second. We've got a little video just saying what the different types of diplopia are and showing the palsy. So now the doctor's going to ask her to follow her finger around the front of the face. And if you watch the left eye as it tracks across, it's trying to now look down and in, but it can't because of the paralysis of the superior oblique muscle. And because that's paralysed, the pull of all the other muscles is just pulling the eye away. There's some great communication skills from the showcase from the doctor. But I thought it was just nice to have a video so you can actually see what it's like rather than just have to imagine it. So vertical diplopia is where the patient sees two visual fields, and that's one from each eye, and they're separated vertically. And to compensate for this, patients tend to tilt their heads forwards, and it's sometimes called a dejected palsy or a pathetic palsy because they look kind of just down because they're just like that. It's a bit of a mean name, but you also get torsional diplopia. This is where the rotation of the eyeball is affected, and this creates two different visual fields which are rotated in relation to each other. To compensate for this, patients tilt their head to the opposite side of the palsy. So if there's a palsy in the left eye, they'll tilt their head to the right to try and correct for this. Patients sometimes present to the doctor saying their neck hurts because they might not notice that they're doing that, but it's going to put strain on the neck muscles. There's a number of causes of trochlear nerve palsy, and depending on the age of the person, it's roughly a third for each. I know that adds up to 4/3, but it's because it's an average over multiple ages. So the main causes are trauma, congenital, ischemic, and tumour. Congenital causes are normally a cause of chronic trochlear nerve palsy. These are normally when there's a problem with the development of either the nerve or the trochlear nucleus in the brain. It can be noticed in childhood, or if it's quite minor, it can only present in adulthood when the compensatory mechanisms start to fail. And this is normally treatable by surgery. Trauma is the most common cause of acute trochlear nerve palsy. Minor trauma can stretch the trochlear nerve, and that can cause blurry vision. More extensive damage will obviously cause more extensive diplopia, more extensive disturbance to the visual field. This tends to recover by itself in a few weeks or months. Other things like diabetic neuropathy, thrombophlebitis, and raised ICP will affect more than just the trochlear nerve. They'll affect the other nerves moving through the cavernous sinus, for example, like the abducens in the ophthalmic, and other nerves as well, possibly. So it's important that if a patient presents to you with what you think is an ophthalmic nerve palsy because of diabetic neuropathy, you check for trochlear nerve palsy as well. And that's it. Thanks for listening.